Hello, my name is Tracy Ediger, and today I will be talking about the who, what, when, where, and why of celiac disease in the pediatric patient. As you know, most of the food that we eat is digested in the small intestine. Nutrients get absorbed into our body through the villi, which are finger-like projections that project into the small intestine. I often describe them to families as looking like a shag rug carpet. The definition of celiac disease is an autoimmune enteropathy caused by a permanent sensitivity to gluten from wheat, rye, and barley in genetically susceptible individuals. So a somewhat complex definition, let's break it down. Basically, it means destruction of the lining of the small intestine, having to do with genetics, and particularly DQ2 and DQ8. The treatment involves avoidance of gluten found in wheat, barley, and rye, and this leads to normalization of the intestinal mucosa. Who gets celiac disease? We used to think celiac disease was a rare disorder, really only presenting in infancy and only occurring in patients of European origin. However, our basic concepts changed with the advent of serologies in the 1980s, with new markers added about every 10 years. We now know that celiac disease is found throughout the world, perhaps excluding Asia, and that the prevalence varies somewhat. You can see in certain parts of Africa, it may be as high as 1 in 18 people having celiac disease. What about here in the United States? In this landmark study by Fasano and colleagues in 2003, he looked at about 4,000 healthy individuals and tested them for celiac disease. He found the prevalence to be 1 in 133. We tend to use 1 in 100 as the general prevalence throughout the world. Who develops celiac disease? There is a slight female predominance, but in kids it's about 1 to 1. The age of onset was initially thought to be early childhood, but now we recognize that celiac disease occurs in all age groups, and there's a current trend towards presenting later and later. We also used to think it was mostly in underweight kids, but several studies, including this one out of Wisconsin, show that in as many as 10%, they may in fact be overweight. There are some associated diseases to keep in mind, including autoimmune diseases such as type 1 diabetes and autoimmune thyroid disease, some genetic disorders, including Down syndrome, Turner syndrome, and Williams syndrome, and in patients with IgA deficiency, which may have 10 to 15 times prevalence over controls. What causes celiac disease? This is Wilhelm Karel Dickey, who is a Dutch pediatrician who was really the first to demonstrate or understand the association between celiac disease and the ingestion of gluten. So we know there is a genetic predisposition, and then there's environmental triggers such as the gluten. Approximately 10% of patients have an affected first-degree relative, and there is a strong HLA association with 95% of patients having the HLA DQ2 haplotype, while the remainder having the HLA DQ8. However, the concordance of HLA identical siblings is only 30 to 40%. This suggests that there may be several other genes involved. So HLA DQ2 and or DQ8 genes are necessary but not sufficient for the development of the disease. Put another way, you must have either DQ2 or DQ8 in order to develop celiac disease. But just because you have one or the other of the HLA haplotypes does not mean that you will develop celiac disease. This is because these haplotypes are very common within the United States, with 30 to 40% of the population having one or the other, with very few of them actually developing celiac disease. In this study from 2010, the authors look at about 4,500 patients with celiac disease and compare them to 10,000 controls. In this study, they found 26 genes to be much more significantly more common in patients with celiac disease, and now the number is closer to 50. And we know that most of these genes have to do with the immune system and immune regulation. Then there's the environmental factor, in particular gluten, which is a protein complex found in wheat, barley, and rye. On average, each of us ingests 10 to 15 grams of gluten per day. However, the threshold for causing damage to the intestine has been shown to be only 50 milligrams per day. How much gluten is safe? If we take a slice of bread and divide it 10 by 10, 1/100th of the slice of bread is equal to 50 milligrams of gluten. So you can see very little gluten can cause damage to the intestine. Within the intestine, gluten is broken down into peptides. These peptides have a high glutamine content and cannot be digested further. These peptides pass between or through the cells lining the small intestine and into the lamina propria. Here, these peptides undergo deamidation by an enzyme called tissue transglutaminase. The deamidated gliadin peptides then can bind to specific receptors on antigen-presenting cells. And not just any receptors, but these are the receptors encoded by HLA-DQ2 or DQ8. The bound receptors activate CD4 T cells that then elicit cytokines that cause damage to the lining of the small intestine. In addition, B cells are activated to develop antibodies against gliadin, the endomysium, and tissue transglutaminase. And these antibodies can be used in screening for potential celiac disease. What does celiac disease look like? The classical presentation is usually in the younger kids, and these are GI manifestations, including abdominal distension, abdominal pain, diarrhea, vomiting, failure to thrive, irritability, and muscle wasting. However, there are many non-GI manifestations, and these are probably even more common than the GI manifestations. These include anemia, canker sores, arthritis, behavioral problems, dental enamel defects, depression, rashes, headaches, and the list goes on and on. I like to say that celiac disease should probably be on the differential for anyone who walks through your door, even if it's way down at the bottom. Here are just some examples. Here is the dental enamel defects involving the secondary dentition. Sometimes this can be the only presenting sign of celiac disease. Here we see the characteristic rash called Dermatitis Herpetiformis. This can be macular, papular, or vesicular. It's usually quite itchy, and there's a symmetric distribution, but up to 90% have no GI symptoms, but if they undergo endoscopy, about 75% have the typical villus atrophy. And this is gluten sensitive, so this rash will go away on a gluten-free diet. Why do we care? Well, non-treated celiac disease means persistent damage to the small intestine. This can lead to problems with bone health, growth, and there is the autoimmune overlap with several autoimmune diseases that I mentioned. In addition, there can be nutritional deficiencies, in particular vitamin D and iron. And there also is an increase in risk of cancer of small intestinal adenocarcinoma and non-Hodgkin's lymphoma. How do we find out if somebody has celiac disease? As I mentioned, the serum markers are extremely helpful and important, but which one to use? Well, the first ones, the anti-gliadin antibodies, are neither sensitive nor specific. And so these should really not be used these days. The one that has the highest sensitivity and is most cost-effective is the IgA-TTG. This is in association with also checking an IgA level. If someone is deficient in IgA, probably meaning less than 15, instead, we would recommend checking the IgG deamidated gliadin peptide. The next step is endoscopy, and probably the most important point from this talk, please, until the patient has undergone endoscopy, keep them on a gluten-containing diet. On the endoscopy, sometimes you can see visual changes, such as scalloping in the middle panel or nodularity seen here in the duodenum on the far right. At a higher resolution, you can see on the left the nice normal duodenum with villi projecting into the small intestine. On the right, at the same magnification, these villi are gone and it is completely flat. More important is looking under the microscope at the histology. There is a specific criteria called the Marsh criteria that is used to grade celiac disease. Marsh 0 is normal. Marsh 1 with increased intraepithelial lymphocytes. Marsh 2, you can see the regions between the fingers or the villi called the crypts are elongated, suggesting damage and regeneration. And then Marsh 3A, B, and C are progressive flattening of the lining of the small intestine. What about genetics? Well, these should really only be used for selective use, probably by a pediatric gastroenterologist, but if you do decide to use them in general practice, please make sure that you are using specific alleles for DQ2 and DQ8, and it cannot be used for diagnosis. It can sometimes be used to rule out celiac disease, for example, if someone is already on a gluten-free diet. But this is because, recall, 30 to 40% of the general population carry these genes, the majority of which do not develop celiac disease. So can rule out, but not rule in celiac disease. The treatment, as we all know, is to go on a gluten-free diet. This means restricting wheat, rye, and barley, and oftentimes oats because they can be contaminated, and patients should know this is a change for life. This is just a list of gluten-containing foods. I think most of us know that bagels and cupcakes likely have gluten, but who would have thought that soy sauce or some of the other things on here might have gluten within them? All children being treated by celiac disease really need to have access to a trained celiac dietitian or educator. Some key words that are not gluten-free to look for on ingredient list include wheat, rye, barley, malt, because it's made from barley, brewer's yeast, and oats because of the question of contamination. Here is a list of potential alternatives to gluten-containing grains, but really a trained dietitian or educator is extremely important. There are other items to consider, such as medications, cosmetics that go around the mouth, school supplies, glues on stamps or envelopes, communion wafers. So as you can tell, there are many challenges to adherence. Wheat-based foods are a staple in the American diet, can be difficult, and requires education by a knowledgeable dietitian. And just having access to these dietitians can also be tough. Non-intentional ingestion are quite common because gluten can be hidden among the ingredients, and it can be difficult to eat out, socialize, and travel. So it can be quite tough on the patients from psychosocial reasons as well. Palatable alternatives are expensive, and gluten-free foods can be difficult to find, although this is less of a problem these days. So the take-home points about celiac disease. It is still highly prevalent in the United States, but often silent. It can occur in all ages. Atypical manifestations are common, and probably even more common than GI manifestations. The IgA TTG and total serum IgA should be the initial test of choice. Biopsy is still required in 2020 in North America. European guidelines do differ a little bit. And please have your patients continue to eat gluten until after they have undergone the biopsy. And finally, education and support are key to maintaining a gluten-free diet, as well as to treating the disease. Thank you very much.